Okay, so welcome. This is the 11th installment of Report Pending. I started this about 12 weeks ago. We didn't put the first live stream on YouTube because it was horrible on my end. But we've kind of refined the process, and so we're meeting every Monday at 6 p.m. Eastern Standard Time in order to help our veterinary colleagues. Sometimes we've had some vet students, people from all over the world. We've had people from the Middle East and Asia and Europe join. So happy to help. I'm excited to have you here. The goal is to give back to our global veterinary community. It's important that this is free. It's important that you have access to the information. On Wednesday of every week, this gets pushed to YouTube at about 7 a.m. Eastern Standard Time. So you'll have that this week. The goal is so that you can improve your skills. So you will, I think, develop and obtain some knowledge, but the goal is skill development. And as such, I think it's imperative that you decide to take a stab at the cases. So I think the most committed that you can be to deciding whether or not there's an abnormality or what a diagnosis is, you can put it in the comments section, or you can write it down. But I think it's different from passively ingesting the information through YouTube or other means where somebody tells you this is pneumonia, somebody tells you that this dog's obstructed. And I think it's a completely different game when I just give you the case, I pause, you get to form an opinion yourself, and then you get to find out pretty quickly. You get that sort of quick feedback on whether you're right or wrong. So I would encourage you to do that. I think one thing that's important that I haven't done in times past that I'll kind of bring up quickly for those of you that are new, the Roentgen signs. So Wilhelm Roentgen kind of developed, it's the first to find the X-ray, the photon. And so we've got these signs that we use. And these signs are size, shape, number, location, opacity, and margin. And so I think it's important as you work through your own cases in your hospitals to practice using these signs, because I think there will be invariably cases that are incredibly complicated or not complicated, but you haven't seen before. And if the instinct is to try to diagnose the problem, so you put up the X-ray and you just say pneumonia, sometimes that works, especially if you've seen the case over and over. But if you get better at saying in the right middle lung lobe, there is increased opacity that partially effaces the blood vessels, or in the right middle lung lobe, the location, there is an alveolar pattern. It will help you get better at working through the difficult cases where you're not really sure what's going on. And is this fat? Is this fluid? Is this gas? And so on. So I would encourage you to write these down. And if you try to take stab at cases, try to catch yourself by saying, oh, that dog's obstructed, or oh, that's an aggressive, that's osteosarcoma. Instead, let's get through the Roentgen signs of where's it located, what's going on, what's the margin, the opacity, and things like that. So I think these Roentgen signs are really important when you start out. As far as the Roentgen signs are concerned, using the chest as an example, I think it's always best to start more general, and then with more confidence in this specific case, you hone down the specificity. So instead of saying there's a lung mass, you could say in the caudal chest or in the caudal thorax, within the caudal thorax, there's a soft tissue opaque mass. And the reason is because you may not be sure if it's in the lung or if it's in the mediastinum or if it's even in the body wall and it's superimposed. And so if you just go straight for the cat's got a lung mass, you may be careful and you may miss the esophageal foreign body or so on. One time we gave away, with the gracious support of a group called IMAIOS. They've got a website. So I subscribe to this. They've given 5 free annual subscriptions to me to give to some of you. And for those of you that haven't been to this site, let me just show you what the site is, because it's really lovely. I use it every day. Okay. So for those of you that can share my screen. So this is me logged in. Okay. And so what you can do is here at the bottom, anything you want. anything that you really want to know, you can find, and you can toggle. What's nice is you can toggle some of these parts on and off. Okay, so if you're overwhelmed with all the annotations, you can toggle some of these off, and you can click these different series. And of course, they've got this for CT and MRI as well. But for you, it may be important to have this anatomy. And so the other thing you can do is practice. It's probably better for some of these. So if you hit practice, it was doing this. Oh no, I wonder if I got to put this on. Yeah, so you can practice if you really want to go nuts. Maybe better for students, but I use this a lot for CT, or sometimes if I haven't looked at certain musculoskeletal stuff for a while, I can pull up and look at different eminences and things like that. So I will figure out how we're going to give one of those memberships away today. Just before I got on, I got an email from a veterinarian based in the great state of Indiana, my home state, that sent me this case. So we're just gonna start with this case and talk about why the technique sucks. But also, and it's not their fault. I think this came from a rescue, and so they're just trying to help out the cat. Without further ado, we'll start with this case, and the goal will be to try to balance answering your questions and talking about differentials and abnormalities and things on cases versus continuing to see a lot of cases so that you can be exposed to a lot of different diseases. Let's give you maybe a minute and a half or 2 minutes, and you can take a look at these three series. I'll maximize them so you can have a better look. The history is it's a younger cat that came in at a rescue and unable to sedate it. Okay, unable to sedate the cat. It's kind of fractious. Okay, unable to sedate the cat, but there was pain in the abdomen, and it really wasn't wanting to use its pelvic limbs, I think, or really wasn't wanting to use its back legs, and just was sort of guarded. And the rescue was sort of maybe we'll transfer it over to a vet and get some more care. So one of the things I like to do that you probably won't be able to do since you're seeing the cases is I like to try to play the game of why did they take the x-ray before I read the history. And that can help you get better at determining, for example, a musculoskeletal, I'll look at all the different digits in the limbs or whatever and figure out why did they take it. And if I detect that there's maybe some subtle swelling associated with the digit, and I look at I look at the history and they say, P3 on the left thoracic limb is painful and swollen, I feel really good. You do that over and over and you sort of get more confident in refining your ability for subtle things. So, so this case, you could form a thought process about what happened with no history, and that would include the signalment. But I'm going to shut up and flick through the three radiographs that we have, and then we can talk about it. All right, here we go. Feel free to start making some comments if you want about what's going on. So as far as the technique, I guess I should be more clear. The positioning, I think, is great. The collimation is pretty good. You've got a cat that you can't sedate or didn't have time to sedate, and I feel like that happens a lot. And the cat's been reported to be painful. And so I think this is pretty good. You got a little bit of the heart, you got the pelvic limbs. The cat's pelvic limbs are pulled cranially because he hurts and you can't pull them caudally. So I feel like that's fine. This VD view is great. I feel like it's really great. One problem is you got ungloved human hands in there, which that's less than ideal. But the position on the patient, he's a little rotated, but boy, oh boy, I feel like that's a really good image. And this is a great radiograph. Okay, so what I was talking about as technique is it's too hot. This was in the oven too long. So you gotta throttle back on the KVP or the MAS. Maybe you could try dropping the KVP by 10% and see what you get. So this thing's burnt out. So it's been in the oven for too long, but it's still, I think, a diagnostic study. And so I think positioning is great. I feel like if you just fire off that first one and go, oh, it's a little too hot, maybe drop the KVP and see what you can get. So yeah, Dr. O'Hara, fractured pelvis. Where are you? You got insert more specific anatomical area here and subcutaneous emphysema. Yeah, so bone opacity, this is great. Bone opacity in the left subcutaneous area. So the way that I would describe this is I would say in the caudal, and then let me see, it was to the right. So I feel like a lot of it's right here. You can kind of see, if you compare this swelling to that area, this is a little bit more swelling. So in the right caudal and lateral abdominal / inguinal area, there's severe, locally extensive, and poorly defined swelling. Within the swelling, there are areas of gas. The urinary bladder is not clearly identified within the abdomen, but is potentially within this area of swelling. To the left of the pelvis, ventral and to the left of the pelvis, there is a angular bone fragment. This likely arises from the pelvis, right? It's not on the ilial wing or the ilial body or the acetabulum or the ischium or the ischiatic table or the femur. I wonder if it's part of it kind of looks like I could expect the cranial aspect of the pubis, and that's the obturator foramen. But the other thing to consider is that these margins are very sharp. And so with a sharp margin like that and good bone quality, you go, this is it's acute and it's traumatic. And then you put together the swelling, and then you put together the gas, and you go, okay. And then you go, this has got long lumbar vertebrae. So this is a cat, and the cat's been involved in some sort of traumatic event that's just happened. And I'm worried that maybe the urinary bladder is in here. It's possible that the urinary bladder is completely empty, and that this is just swelling, a seroma, an abscess, all the above. But I guess for me on this cat, you could talk about the prepubic tendon inserts on the cranial aspect of this pubis. And so if you ever have trauma to the cranial aspect of the pubis, you do need to worry about a body wall that's sort of herniated down. And so I'm not sure that that's necessarily happened, because this looks like it's trying to come up. But I think there's a lot of trauma that's been sustained to this area. So what I would probably do is throw an ultrasound on here and see, can I find anything that looks like urinary bladder, to give me an idea if it's entrapped. If you really want to go nuts, you could do a retrograde positive contrast cystourethrogram, drop a urethral catheter right in here, positive contrast, maybe 50-50 with saline, drop it in here, and then you'll see what's going on. Maybe it drops in here, maybe it's empty. And then obviously a CT would be ideal with contrast as well, because that could help determine the integrity of the body wall. So I don't know if that's helpful. Cat is eating well. These cats, what they do is they go out, they have dinner, and then they go out for a little bit of a walk, and then they get hit by a car, or they jump off a balcony or something like that. So this cat sustained trauma to this caudal area, and I'm worried that there may be some more serious sort of entrapment of the urinary bladder. I don't really see an intestine. The gas could be a result of secondary abscess development. Chased by 3 dogs 2 weeks ago. So the dogs bit the poor cat here. And so because it's happened a while ago, like, I don't know if that's the urinary bladder, maybe that's an abscess. Clearly there's gas, and the gas really shouldn't be there this long after the fact, unless maybe there's a secondary abscess. So, yeah, could be ideal if you don't have a CT to do a retrograde cystourethrogram, find out where the urinary bladder is. You could also do the ultrasound, harpoon any fluid-filled structure, with the caveat that, you may want to make sure you're not seeding infection into the urinary bladder. But if it swells, stick it, was how I was trained. So, yeah, technique was good. I think I was a little bit critical. I can be critical, but I feel like the technique was pretty darn good. Just a little too hot. Doc Steve is asking about some kidney. Here's a left kidney right here. Here's a right kidney. So kidneys in intact younger cats, they look big. So here's a kidney. Here's the left kidney. And here's the caudal pole, and there's the cranial pole of the right kidney. And the kidneys are superimposed with each other. These are in JPEG, so it's difficult to window and level. And sorry, I can't window and level, and it's hard to zoom. The left kidney's fine. I think it's okay. Retroperitoneal serosal detail. Let's say you were like, well, this is an odd kidney. Maybe he sustained trauma, a bite wound to the kidney, and he's got some hematoma in the kidney or whatever. The retroperitoneal space looks great. You can see these fascial planes within the fat. You can make out 2 kidneys nicely. So I think the cat is left kidney's okay. All right. Let's party. I'm gonna really trick you guys. Let's do pulling up Horos. Also, let me know. Feedback is helpful. What you guys need, what you want. One of the challenges with 12 different people signed in at once is the training level, the education level, the experience level can vary. And so some people may think this is really elementary, and other people may think, oh boy. So I'm not going to assume anything other than you don't know much. Okay, so this is like a chondrodystrophic dog. He's a 3-year-old male neutered dog. He's acutely limping on his right pelvic limb. Okay, go for it. Okay, this is a pretty short case. What do you think? Anybody see anything wrong? Why? We took this radiograph because the patient is lame on his right pelvic limb, and the owners are spending a ton of money, and they've waited for 4 hours, and we got to tell them why the animal is limping and what to do about it. And I got an idea. The infrapatellar fat pad looks too opaque. I agree. So one of the landmarks that we use, you can't really see it here because this is the dog's condyles are a little bit less well developed than, say, like a larger breed dog, but there's the intercondylar fossa, that longitudinal extensor tendon comes through. I kind of use that as a cranial landmark or a cranial border for whether or not there's too much opacity in the stomach. In other words, you will sometimes see triangular and fairly discretely margined soft tissue within the stifle joint that represent the menisci. And so this border is fairly straight, which is not always common with effusion or hyperplasia within of the synovium within the stifle joint. And so the game you play is when I can see that divot in this condyle from the fossa, is the soft tissue cranial to the little divot? And then you go, okay, yeah, it's too. So this patient, I think there is too much opacity that's out here. Even though I can't see that fossa, I still think there's too much. The other thing that you want to look for, is there's fat within the gastrocnemius fascial planes caudally. So you'll see the fat that kind of goes up here, and there's too much soft tissue back here. But Dr. O'Hara is on point, dude. This case, I feel like, is a whole reason that I pulled this up was she called it. So the tibia a bit too cranial, fat pad compressed. So this dog is in cranial drawer. So this next time you look at a stifle, and I'll pull one up next to it, but these condyles, if you drop an anchor, I mean, it's not even in line with the tibia. That thing should be right up about here. The intercondylar eminences are a bit wimpy in this dog as well. So again, I apologize, not making the best teaching case, but what will happen is these condyles really should sit in the vicinity of that intercondylar eminences, which will probably be right about there. Okay, so this is a cranial drawer. So this dog diagnostic, like this test is diagnostic for a rupture of the cranial cruciate. Maybe Dr. O'Hara can take over from here and just do the rest of the presentation because she's on point. This one we don't want to talk about. I would also look hip joints fine. We don't talk about, you probably know, we don't talk about joint space width in small animals. The lateral and medial pabellae of the gastrocnemius, they can be asymmetric like that without talking about some sort of avulsion of the medial head of the gastrocnemius. So that it's probably symmetric. I think there was like a paper about that maybe in terriers, fox terriers. I'm not sure, but that's normal. Don't worry about it. So this is a cranial drawer. That's why we did it. This came in today. This patient's based out of California. And it's a younger animal that is vomiting and has diarrhea. There are 3 views, right lateral, left lateral, and a VD view. And go for it. Okay, is the dog obstructed? Right, that's why they took it. That's why you take it. So, all right, come back to the right lateral view. Does the dog have a GI obstruction? Are you worried that he's got obstruction? Does he definitely not have an obstruction? What are the abnormalities? What do you got? All right, Steve, I like it. So he's talking about stomach's got some fluid and some gas. Left lateral view is a convex gas opacity of the pylorus. Worried about maybe something causing an outflow obstruction. Okay. Some of you, I think a lot of you, or at least some of you have been here. So I don't know if I should go through the whole process of how I interpret the radiograph. But as far as the GI tract goes, this is the stomach right here. So this whole thing is the stomach. And then when you flip the dog over, this border right here, this whole thing is the stomach. And this whole soft tissue looking structure, stomach tapers down to the body and the pylorus. So I would say the stomach has that's a lot of fluid. The left lateral view. So for those of you that maybe haven't been here, this is a great example of when you redistribute fluid or at least GI contents based on laterality, right? So if you take this as an example and you take the right side of the dog and you stick it on the table, okay? So imagine that this was right side down. X-ray comes through here like that. And if the dog's right side is on the table, all the fluid goes down into the pylorus and it looks like this. But then if you flip the dog and you put the left side down, right, here's the pylorus, all the fluid rushes down to the fundus. So it goes flying over here. And then you have something that looks like this. So there's gas in the pylorus. And that's what you want to see. You don't want things to be stuck in this pylorus on the left lateral view, because as Steve mentioned, you get a concern about a pyloric outflow obstruction. Now, I don't think that the dog has a pyloric outflow obstruction. I think that this is gas in the pylorus. I think the stomach comes all the way around here. It's full of fluid, and then it's got a little bit of gas with fluid and then all gas. This structure is the colon. Okay, and I feel pretty confident that it's the colon for a couple of reasons. But one, we've talked about that the colon should stay in this plane. The dog's pretty straight. It should kind of stay somewhere in this plane on the lateral views. And so you got a very large gas-filled structure here that is in plane for the colon. Could it be the small intestine or the duodenum? It could, but let's not panic, because it also, if it was down here or if it was maybe way up here, we would have a different story. But I think here it's fair game for it to be the colon. And then the colon kind of comes around here and it whips up around here, and then I kind of lose it, but it's probably here. So the colon also has a ton of fluid in it, some metal fragments. The rectum has some metal fragments right here, mineral metal. But I also think this is a case where the small intestine is a little bit too dilated with fluid. And that's a hard game to play, because if you take the gas out of the small intestine and you collapse it down, it'll look opaque. If you put a little bit of fluid in there, it'll look opaque. It's just a little bit bigger. Is it too big? Is it empty? I don't know. I think this is a case of the dog has gastroenterocolitis. So maybe it's from this foreign material, maybe it's from parasitic or infectious etiologies. Maybe he's got IBD, maybe there's Addison's disease. So I think this is a case where it would be good to ultrasound now, but I'm not concerned. I don't have a high level of concern for a GI obstruction. There's this much fluid, there's stuff getting through to the colon, and a lot of the small intestine probably has fluid in it. The other thing this could be too, it could have pancreatitis. This much fluid, to Steve's point, is that you should probably follow up on this patient. So I don't know if you need to rush across town and get an ultrasound, but I think if you, one avenue would be 12 hours of controlled fasting with supportive care, and you repeat the RADS to see if the stomach is empty. If the dog doesn't vomit, he doesn't eat, and you repeat the RADS and the stomach is less distended with fluid, you're on your way. It has to have moved downstream. The other thing you could do is ultrasound them in the morning. But I think the degree of gastric fluid accumulation warrants some sort of follow-up imaging. Any questions about this one? It's a pretty straightforward gastroenterocolitis. There's a left kidney. There's the caudal pole of the right kidney. This right kidney looks smaller than the left kidney because of the effects of magnification. So when the right side is down, the left side is further away from the table, so it gets magnified. The other thing I wanted to show you was this patella is luxated. So probably the left pelvic limb. This femur, same thing with magnification. My guess is that this is the left femur. I don't have the right in the field of view in order to compare size and sharpness of margin, but my guess is that this is a left pelvic limb. And I can't tell you if that's a medial or a lateral luxation, but it's a small breed dog, so chances are it's medial. Cool. Cool. All right, here we go. Next case. Okay, I'm just going to show you. This is a fluid-filled and or thick-walled small intestine in a cat. You see how that just, you could save this and just burn it into your mind. All these loops, they're making nice gentle turns. Everybody's just kind of sitting there, plopped together. Everybody looks like they're the same size, but they're all a little bit too big, and they're all opaque, which means they're either thick-walled. The likely chance is either it's only fluid, or it could be a little bit of wall thickening with fluid. You could also have small cell lymphoma that would just totally obliterate. It causes wall thickening. Maybe there's no fluid. The point is that I think there's a great case of enteritis in a cat. The lack of serosal detail in this particular patient, Doc. I think Dr. Sanderson's asking about a lack of serosal detail in this particular patient. If he's talking about this particular patient, I think the dog. Yeah, I think that could be from overlapping loops of small intestine and fluid-filled. Would I be surprised if maybe there was a little bit of inflamed fat? I think it's possible. But I still see some of the fat here, fat here, fat here, fat here, fat here. When you take, I think to your point, you could maybe comment that the serosal detail is a little less clear than desired. You'll notice here he's got streaking hair. I don't know if you can see that. He's got hair out here, so he's probably wet. And the hair down here, you see all this hair, it's wet. That'll contribute to loss of serosal detail. When you have a bunch of fluid-filled or thick-walled intestine and they sit on top of each other, and then the colon's full of fluid and the stomach's big and it causes some crowding, and then you got the spleen in there, it can kind of cause it to look a little bit, a little less. Serosal detail's fine here. So I think it's probably okay. But if you plop the ultrasound probe on him and you saw a little bit of inflamed fat surrounding the intestine, if you get a really pissed off gut, the fat around it will be inflamed on ultrasound, even though there's not peritoneal effusion, and that will contribute to a reduction in serosal detail. Okay. Acute vomiting in a 3-year-old. No, I lied. You can tell I'm lying because the dog's back is toast. This is a 12-year-old male neutered Chihuahua mix that's got progressive abdominal distension. Okay, here we go. So, Doc O'Hara, stomach mixed opacity, likely ingesta, mass effect pushing intestine to the right, something, RHS. Mass looks fat, opaque, giant lipoma, back spine, awful. Yeah, mass effect pushing stomach, likely. Right hand side. Okay. I think this is a great case. So remember I talked about those Roentgen signs? So this, well, okay, I'll start with the way that I normally do it. So the caudal thorax, I think, looks pretty good. The liver is too big. So that rounded margin right there, it's just a little bit too big. I do think this is mostly food, probably all food. This is the left kidney. That's the right kidney. That's the urinary bladder. The spine is trashed. This L2 vertebral body does not have a lytic focus. Dog's so rotated, that's probably the colon. But the dog's got significant degenerative disc disease throughout multiple sites of its thoracic and caudal lumbar spine. So here's the left kidney. That is the right kidney. The right kidney should be up here, so it's displaced caudally. There's the splenic head, this triangle of love. That should be up here. And all the intestine can do this in a cat. Just kind of bunch up in one side, but it doesn't do that in a dog. And so There are multiple areas of organs that are affected by a mass effect, because I'm having a hard time seeing a mass. Remember, mass, you should see a border. Mass effect, you see the impression of a mass. In other words, it's pushing, displacing things. So this right kidney is displaced, the splenic head is being displaced, and all this intestine is being displaced. And the displacement is coming from this, all of this, okay? And when you look at this, even though you don't see a mass, what you see is you see an opacity that's different than this opacity, that's different than this opacity, and it's different than this opacity. So I know that this is the left kidney. I think most of you know that this is a kidney or a mass of some sort, but you know that this is the kidney. And so even if you didn't know that was the splenic head, you go, this is the kidney, and so this is less opaque than the kidney. Well, on my little scale of opacities, it's gas, and then it's fat, and then it's soft tissue. So this doesn't look like gas. And the reason it doesn't look like gas is because I have gas up here. So it's not black like that, but it's not white like that. It's sort of medium, and it's got this middle opacity. And so that is fat. So this is a very large intra-abdominal lipoma. And it's just smashing everything out of the way and pushing things. And it may not actually be a huge problem. This is quite dramatic and maybe posing some GI issues. I forget exactly why the animal was here. But this is just to show you that don't jump to there's a giant mass in the abdomen. I think if you work through it, you then immediately, the owner, you don't ruin their weekend. Okay. What else? I don't see the prostate gland. I think that's the urinary bladder. I don't see the prostate. I thought maybe there's something hiding in here prostatic wise, but I don't see it. Spleen, liver, bad back. That kidney's maybe a little too big. Questions or concerns? 6 radiographs, 246, dated January 5th, 2023. Yeah, I like it. So I like this large round soft tissue opaque mass mid-ventral abdomen. So a lot of Roentgen signs there. Where's the right kidney? Spherical opacity looks too rounded to be a bladder in position to cranial. I agree. Where's the right kidney? I'm going to show you. It is, I don't see it. Here's left kidney. I don't see the right kidney. This is left kidney. Left kidney is a little bit too cranial. Right kidney can be sometimes difficult to see. I think that's the left kidney still. I don't see the right kidney. Oh, Steve is on it. Okay. One thing at a time. I'm not sure that I see a right kidney. Okay, so this isn't the right kidney. It's not the right kidney because this is creating a peritoneal mass effect, right? A retroperitoneal mass effect would look like this. Okay, this is a retroperitoneal mass effect. You see how this thing's up here, and all the intestine are kind of getting pushed down here like that. And so this case is this is probably a right renal mass. The left kidney's kind of big too, but this is a mass over here. So this is a retroperitoneal mass effect. Okay, that's not what we're dealing with here. Here you can see this one's sitting down in the mesenteric cavity. So this is a peritoneal origin. So we don't see the right kidney. Could be from aplasia, hypoplasia, severe chronic kidney disease. Although I do find it interesting that the left is not particularly hypertrophied. Kind of draw, crank out all the slack from the left. So yeah, I like that. I like that observation. But the salient one is the mid-abdominal mass. And so one of the things, I always start with the anatomy. So I say in the mid-abdomen, there is a large mass. And then you could talk about that it's smoothly outlined and it displaces intestine and all that. The importance of using the Roentgen signs is you would say that the majority of the mass is opaque and it appears to be soft tissue opaque, which would then mean it's either fluid or soft tissue or both. You can't tell the difference. But you'll notice that it's got this rim around it. And the rim could be gas because your internal control of gas in the intestine, it kind of looks like that. And so I think it's a wise guess. Could this be intestine? But this is a necrotic intra-abdominal lipoma. So you've got an intra-abdominal lipoma that has sort of a soft tissue opaque rim, and then it's got fat, and it's almost always fat. But when it becomes necrotic, the necrosis becomes fluid, and then it attenuates more of the X-ray beam. And so you still sometimes have that mantle of fat interposed between the necrotic component and the rim. And so this is a necrotic intra-abdominal lipoma. And this is a great case of a loss of serosal detail. When you look at these margins, you'll see these wisps of fluid here in this fat. So the fat down there is supposed to be very homogeneous. So you'll see these striations. Let me see if I can get a better. That's a good spot right here. See that? There's these little faint striations right here. Right here. Here's probably the best shot. Right here. Maybe there's some wisps right here, but this, see this border? That's splenic tail, and that's adjacent fat. And see that border is really rigid, or not rigid, really clearly demarcated, and that one's really clearly demarcated. But look at this margin. It's just kind of a little bit indistinct. And that's because it's either fluid or a little bit of steatitic fat. You inflame that fat, and it's going to reduce the serosal detail. So I don't think this is some ectopic, weird ectopic right kidney from trauma or something like that. I think it's a necrotic. It was confirmed necrotic lipoma. So another good example of Roentgen signs, it would be, these aren't common, and it would be much more common to have a splenic hemangio with a hemoabdomen. But it's another one of those where you go, well, what in the world's going on? Why is this thing not completely soft tissue opaque? So just be careful. Don't euthanize the dog. This dog's going to do great. Just needs another kidney. Okay. This is a 15. I made that up. I'm making all the histories up if you hadn't noticed. Sorry. This is a 7-year-old dog that the owners have felt like the leg it's like got a firm swelling in it. Okay. So I'm going to give you two views, left lateral view and a caudal cranial view. Okay. All right. What you got? Anything? Can we tell this owner why the dog, maybe he's a little bit lame, but he's not awful, and they just pet him by the fire. Good. Everybody's picking up. This is good. So one of the things that I did was I have a small radiology company, and we got a client referred to us through a Facebook page, and I didn't have a Facebook account, but then I thought, well, shit, maybe I should get one. So I got one, and then I started noticing in these Facebook groups that there was vets helping vets interpret radiographs, and I would look at some of the comments, and some of them were not correct. And I thought, well, how can I help them? And one that I saw this week was somebody was very concerned about a mass in the dog's leg. And I could reach out to these vets that post them and all that, but maybe they're embarrassed or whatever, and it's fine because radiography is difficult. And so I just thought, well, maybe I'll just find something similar. And so this is very similar to a case that was posted in a vet-to-vet group. And so I thought, well, shit, maybe I should make sure that some of my group, my team, know and aren't going to be fooled. So it looks like none of you are. So this view, you can see it. There's something, I would say, in the caudal thigh, there is a large ill-defined mass that is mixed soft tissue fat. On this view, I would say, oh boy, there's a very large, predominantly fat opaque mass. And you can measure it and all that. And so, again, you've got all the opacities, right? This is a muscle, so it's soft tissue. This is less opaque than that. This is mineral, so it's mineral. So it's like metal, and then it's mineral, and then it's soft tissue, and then it's something less than soft tissue. So if this was hemangiosarcoma or an abscess or a rhabdomyosarcoma or some other sarcoma, you wouldn't see it. It would look like this. And so this is an intermuscular lipoma. It's a common location for intermuscular lipomas. They like to hang out between the semimembranosus and the semitendinosus. But the point is, use the Roentgen sign. So you go in the caudal left thigh. There is a very large mass. The mass has areas that are well-defined and bulbous, and some other areas that are less well-defined. The mass measures this size, bop, bop, bop. The mass is less opaque than the surrounding soft tissue, and therefore it must be fat. And then you go, oh, instead, you don't want to go, oh, there's a giant mass in the dog's left thigh. there's a giant tumor or something like that. It is a tumor by definition, but it's a lipoma, and the dog's going to do fine. The dog has some OA in its stifle joint. That's that extensor fossa I was talking about. I think there's a little bit too much of a wisp here. There's a nugget of love on the proximal aspect of the femoral trochlea, little ski slope on the lateral aspect of the tibial plateau, and that's a bit of a trashed left hip joint. So don't be fooled by some of these things, but that's the whole. That's really it. I get into I just mining for how I can help, and I see some of these, and people are getting a little bit hot and bothered about these masses. Dr. Sanderson, can you repeat your Stifle OA assessment? Yeah. Okay. So this is a great properly positioned radiograph because the femoral condyles look like damn near one condyle. So these are perfectly superimposed on one another. And see these intercondylar eminences right here? These femoral condyles, there are two, medial and lateral, they're in close apposition to that intercondylar eminences. Remember that other case where you could drop an anchor from the condyles and it was back here? Okay, so one of the ways you get that is you just try to flex the dog's tarsus to get him in cranial drawer. So I like the flex tarsus view to try to give me as much evidence as I can that the dog has a cruciate injury. If it's a chronic cruciate injury, it's fibrosed down, and it's going to be less likely to give you that give. Okay, but this fossa, the external fossa, you can see it. It's a little lip right here, and on the you can see it right. See on this one too. See that little radiolucent divot right there? So that's an extensor fossa, and it's on the lateral aspect, which sometimes you can see it on the lateral aspect. Okay, but I'll go back to this view. Okay, so this is a right stifle joint. So this has increased soft tissue opacity. So this case, I would say increased soft tissue opacity partially effaces the infrapatellar fat pad. We don't really think it compresses it or displaces it. We could just say it effaces it. So instead of being fat, it's got a mixture of soft tissue with fat. You'll also notice that this fat right here is, we call it in a gastrocnemius fascial plane. So that's the supracondylar tuberosity, and this is the gastrocnemius. So fat within this plane, you should see fat go all the way up to these fibelli. So this nugget right here of soft tissue is actually fluid and or synovium punching out the back of the stifle. So I've had cases with cruciate rupture where you just see this loss back here, and this doesn't look that dramatic. So this is pretty marked increased opacity. You got to be careful. Like, could this be fluid? It's probably fluid. Could it be synovial hyperplasia? It probably is both. So to say this is just diffusion, I don't know. There's a little mineral nugget that could be dystrophic mineral of the menisci, of the inflamed synovium, maybe an avulsion of the cruciate, but I don't know. That's kind of less common. So to me, this looks like there's increased soft tissue opacity, partially effacing the right infrapatellar fat pad. Fat within the gastrocnemius fascial plane is effaced caudally. Where's my right lateral, my caudal cranial view? So this calcanean, the calcanean tuberosity, you want it to hit right in the middle. So he's a little rotated, and plus this isn't a great view because it's, well, he's a little rotated. It's fine. It really is fine. This is pretty good. Okay. But this little nugget right here is a ski slope off the lateral aspect of the tibial tuberosity. So that's a real common area. I feel like we'll see a little bit of OA. There's a little bit of OA. Periarticular. So it's periarticular. You got some irregularities of the condyles. There's periarticular new bone formation. So I would say there's mild periarticular new bone formation in this, a little bit of irregular new bone formation there, and also right there, though it's superimposed with that restraining device. Okay, so this, to me, you could just diagnose this as mild joint osteoarthrosis, because with osteoarthrosis, you'll get swelling, you'll get hyperplasia, you'll get periarticular new bone formation, and the most likely top three differentials are a torn cruciate. So that's the Stifle joint assessment. This is probably an enthesophytosis. Patellar ligament looks pretty good. There's maybe a little bit of OA on the proximal aspect of the femoral trochlea. The tarsocrural joint looks good. Popliteal lymph node is right here. I think that was thrown out as a differential for intermuscular lipoma. This is the popliteal lymph node right there. Okay. On that lipoma case, maybe it was being distorted. Let's call it quits. Learned a few things, going to bed a little smarter than we did yesterday. I feel like that's great. Let me know in the comments. Catch the edited version on YouTube. I think you just put in my name in the YouTube search and it'll come up. Let me know in the comments of the YouTube. Let me know in the comments here. Email me and let me know if there are specific things that you want to see. So hopefully this is helpful, and let's save some animals tomorrow. All right, guys, have a good night.